May I at the outset say how grateful I am that I was invited to be part of this meeting, and also how grateful I am that a lot of the meeting has turned out to be about Mbali, because my home happens to be a few kilometers away from Mbali in Uganda. So it is quite humbling to hear how much you are doing and how much we are talking about improving health services in Mbali. I looked at the program where already issues of strengthening health systems had been included, and I decided that I would talk a little bit about the context of this health system, and then also reflect on the various international and continental obligations that many countries in Africa have to look at some of the solutions that are African born, and focus on two initiatives: the stronger ministries of health for stronger health systems, and also what we are doing in EXA Health Community on the aspects of global health diplomacy. And I shall then reflect on what, in my view, the future looks like. Of course, you are all familiar with the African challenge: very high disease burden, diminishing resources, and decreasing share of the world resources. The discourse, increasingly from the African perspective, is on mobilization of domestic resources for health. We have experienced over the last 20 to 30 years exponential population growth, but in most of the countries, these have not been accompanied by proportionate economic development or growth. There is lack of cooperation or synergy among sectors, among different role players within the health sector, which creates different challenges within the health systems that need to deliver on the health needs of these populations. And policy incoherence is more the norm than the exception in many of our countries, where one ministry may be talking at odds with another. But there are lots of ideals, including the ideal that is driving the current AU strategy, the Agenda 2016 on the Africa we want. That has been, to a great extent, strengthened by the resolution on the Sustainable Development Goals on leaving no one behind. But obviously, as I stand here and as I was listening to a lot of the discussions this morning, I was very happy that I put that last question there. Is there an African health system? Because the health system in the 54 countries are as different as they can be. And even within each of those 54 countries, you might find a lot of differences. But I was asked to talk about strengthening African health systems. I came across this showing that by the year 1500, that was the African share of the world wealth. And by 2015, one would need a microscope to see how much of the global wealth Africa held. And that needs to be seen in the context of the mobilization of domestic resources for health with that diminishing share. And that could be translated when one looks at the various aspects of the health systems blocks: the health workforce, health financing, and so on. The share has definitely diminished. So I'll briefly talk about the commitments. When one looks at the constitution of the World Health Organization, the Alma Ata Declaration that has come up in our discussions, there was the Ottawa Charter on Health Promotion, and so on and so forth. A lot of the issues on health for all do come up. the issues of having health in all policies, the issues in making health central to everything we do, have been addressed either directly or indirectly in very many commitments. And this was what that Helsinki statement included, that we need to prioritize health and equity in health as a core responsibility of governments to its people. We need to affirm the compelling and urgent need for effective policy coherence, and that we need to recognize that this would require political will, courage, and strategic foresight. And in your experience in many countries, I think you can see some of the areas in which many of our countries are faltering. The context of the health system can be varied. I borrowed this, which looks at the central role of the health in all policies as encompassing everything that includes the health of the populations, the personal or individual health services, but also the components of knowledge generation through the various research systems as one that we need to keep in mind, so that as we look for innovation, as we seek to scale up what is working in some of the areas we're working, we keep this context in mind. But I also thought I should remind you of the kind of environments that many of the ministries of health operate in the countries that you'll be going to work in. You will have the Minister of Health reporting either to the Prime Minister or President or both. He also reports to Parliament. But there are also parastatals and semi-autonomous organizations. Could be the prison services, could be some of the other specialized agencies that are also offering help. There could be, not could be, but there are ministries very relevant to the health budget, finance, environment, agriculture, and so on. And within the country, there is a myriad of various role players, all of whom are contributing to the health resources that this minister is supposed to take care of. And ultimately, when the system becomes dysfunctional, as was exposed in West Africa, the buck stopped with the ministers of health. These ministers of health were held responsible for the weak health systems that were so dysfunctional that Ebola spread very fast. But when you look at the complexity of the various factors, the various role players that they have to play to answer to, one becomes perhaps less forgiving. During the height of the health workforce crisis in Africa, this is how the permanent secretary, Minister of Zambia, indicated the complexity of the situation, that there was so much happening that was resulting in a public health disaster through lack of health workforce. A lot were getting out of the system, lots were getting, as we have even had through some of the discussions here, leaving the public health system to the NGOs and so on and so forth. There was a lot of attrition of health workers at that time due to high mortality due to HIV and AIDS. Of course, the low salaries and lack of incentives, they are leading to lots of low motivation and poor outputs and so on. But once again, you could translate this to virtually any of the 6 building blocks of the health system, and you will understand how complex it is. The Sustainable Development Goals, and I appreciate very much the way WHO creatively reworked them to put goal number 3 in the middle and ring the rest of them. And I think those of you who have been to Geneva will see this prominently at the entrance to the WHO building. And I think this offers us a lot of hope in trying to mobilize resources from the other sectors to ensure that well-being across the life spectrum that goal number 3 speaks about. It also makes our roles as we engage with the health system that much more complex, because suddenly the trees that we are seeking to plant actually make a lot of sense in the context of a sustainable world, in the context of a better world, and in the context of more healthy lives for all ages. And these are some of the truths that have been put forward, that health is central to the 3 dimensions of sustainable development, that is the social, the environmental, and the economic. That health should be looked at as both a beneficiary and a contributor to development. It wasn't always the case. Those of you who have been in this field much longer than I have will know that for a long time, getting allocation for health was a problem in many of the development agencies because it was seen as an expenditure. I think thankfully now it is being seen as an investment. And health as an important end in itself, but also as an integral part of human well-being is again an issue that has become much easier. And health as an indicator of what people-centered, rights-based, inclusive and equitable development should achieve has also become easy. The Sustainable Development Goals with those 5 Ps, the focus on people, the planet, prosperity, peace, and partnerships, does once again make it a little easier for us in the health sector to sell some of the ideas that we have been grappling with over the years. I'll talk briefly about one of the commitments that is driving African health systems, and that is the Africa Health Strategy, which is for 2016-2030, and it is supposed to actualize the bigger Agenda 2063 on the Africa we want, together with the Agenda for Sustainable Development Goals. But it does build on a number of pre-existing continental commitments. The one on sexual and reproductive health and rights, policy framework, and the extended Maputo Plan of Action. The Maputo Plan of Action was initially up to 2010. It has been extended up to 2030. There is the Pharmaceutical Manufacturing Plan for Africa, the Africa Regional Nutritional Strategy, lots of Abuja commitments, the most famous of which is the Abuja commitment of 2001, where the governments in Africa committed to allocate 15% of the national budgets to health. And as we speak now, about 4 or 5 countries only have reached that target. And the reasons have been debated among the African heads of state and ministers of finance interminably, but we continue pushing and reminding them. But of recent, there has been a push to an adoption of a catalytic framework to end AIDS, TB, and eliminate malaria in Africa by 2030. That is giving a lot of impetus to a lot of effort and a lot of resources to go into the health system. The Africa Health Strategy also recognizes the global strategy for Women's, Children's and Adolescents' Health, 2016 and 2030. And all this collectively drive a lot of the efforts among the governments within the countries. For an audience such as yourselves that work in many of these African countries, I need not dwell on the fact that many of our ministries of health are weak. And to that end, we have undertaken deliberate efforts to strengthen the stewardship role of our ministries of health so that they are able to drive stronger health systems. And among the things we do is to prepare our ministers and the ministries, particularly the senior officials, to hold their own through building political, diplomatic, and people skills. One of the observations that we have made is that when a new minister is appointed to the health docket, they get in and immediately get overhauled. The budget is small, the disease burden is high, there are so many different role players, and it becomes even more difficult and intimidating for them if they are not of a health background. So we have a deliberate process in empowering them to hold their own better in that new space, and also to define the agenda within the ministry and also among the partners. But we also try to build the technical capacity of the senior ministry staff, with emphasis on the fact that it is incumbent upon the Ministry of Health to ensure that they take stewardship of the health of their people. That is something that they cannot cede to Wales for Africa Health Link, however well-intentioned it is. They cannot. Wales for Africa Health Link is a welcome partner, but they will do very well if they find effective stewardship of the health in a particular country. So we have conducted research that has exposed and also found some strategies around some of the weak evidence gaps, and we have devised ways of promoting evidence-driven policy frameworks to bridge some of those gaps. We conduct executive leadership and management forums that include ministers on the sidelines of some of our ministers' meetings, but also for our senior officials. But overall, the intention is to have better leadership and governance for the health sectors in these countries. Because ultimately, all the other 6 blocks, all the other 5 blocks of the health system fall apart when leadership and governance are weak. The fundamental considerations in this are informed by a few points. One is to be an effective steward of health resources. The Ministry of Health must do more than deliver health care, because ultimately it has to coordinate others that are also delivering health care, not only delivering health care. That it is critical to understand the country context in which health systems transformation must occur. Obviously, most of the African countries are 50 years old since independence. They have been doing things in a certain way. And if the health indices are anything to go by, we cannot continue the way we have been. So elements of transformation have to happen. But in order for those to happen, we must recognize the different country contexts. The other consideration is that there must be a critical mass of capable actors within the countries to to drive progress towards such transformation if it is to be beneficial to the countries. And of course, the challenge in many of our countries, and I think that is one of the points the minister who spoke before me alluded to, without using the same words, the people who should do something about something feeling so disempowered that they just look on and the labor ward goes for 3 years without light when they could actually do something about it. So the transformation that needs to come from among the people that are on the ground within the resources that are already in existence. Those are some of the things that drive our processes. In the East Central Southern Africa Health Community, we have a strategic initiative on global health diplomacy. And this arose out of a resolution taken by our ministers in 2010, urging the member states to strengthen their capacities in global health diplomacy. You are all familiar with global health diplomacy, which is the link between what used to be the realm of diplomacy, what used to be global health, and the combination between the two. And it is through that we've held, as I indicated a short while ago, some seminars for ministers of health and senior officials. We have held on a number of occasions over the past 5 to 6 years workshops for the senior officials and technical staff that accompany our ministers to the World Health Assemblies, during which we go through the agenda, identify the most critical issues that are coming up in the World Health Assembly. And the colleagues that are following this up closely have noticed that the engagement from our region in some of these forums are getting more substantive than was the case before. We have also created a bridge between our countries and the missions in Geneva, because unfortunately not all our countries have health attaches who are health professionals in Geneva. So when they receive the massive agenda for the World Health Assembly, they can't make head or tail about what is coming up. So we hold discussions with them ahead of critical stages such as the Executive Board and the World Health Assembly itself, where we equip them to facilitate them to brief the countries much better on what is coming up. One of the initiatives we are most proud of is the collaboration that we have had with the University of Nairobi, through which they have developed a master's program in global health diplomacy, and I think this is going to be the first in Africa. It went through all the various stages within the university processes, and they are ready to admit the first students to this master's program in this coming academic year. But there have been other collective efforts. Human resources for health remains one of the biggest problems we have in the region, and one of the biggest reasons we have weak health systems. As the East Central Southern Africa Health Community, we have, with the professionals in the region, developed colleges along the Royal College models, through which a number of professional trainings, specialist training are happening. And the model is working very well. The East Central Southern Africa College of Surgeons, COSEXA, has done very well. And it has indicated, among others, that the retention of the specialists through this model tends to be much better than the retention of the specialists through the University Masters of Medicine training. We have established expert committees on topical areas such as health financing, We have looked at issues of national health accounts to help our countries improve the efficient utilization of the health expenditure that is allocated to the resources. And we are also engaging with those that are involved in innovative ways of health financing. We are engaged through a number of partners, including the World Bank, the Global Fund, Rockefeller Foundation, USAID, in various regional initiatives to build capacity in different areas, such as diagnostic capacity, areas of emergency preparedness and epidemic response. It is unlikely that an Ebola outbreak within our region would ravage it as bad as it did in the western part of Africa, partly because of some of these initiatives. And we are working actively with the countries to implement the International Health Regulations 2005, many of whom are lagging very behind. And we are engaging very actively in the global health and security agenda. The health was missed out, but that's the global health security agenda. That includes antimicrobial resistance. We have done a scoping to understand the gaps, particularly in the diagnostic capacity of our labs to identify antimicrobial resistance. And the World Bank has committed some funds to help us take this further. What I haven't put here, but I was reminded when I had some mention, we have an ongoing project looking at beefing up cancer registries within the East African region, and we hope to take this to the rest of the countries. I've been moving very fast, and I'm about to stop. So I'll say most of the battles towards the attainment of the Sustainable Development Goals will be in Africa. And that's where the efforts should be as well. And just to say, the Health for All by the year 2000, which was the rallying call of 1978, was real about Africa and other developing parts of the world. The Millennium Development Goals were real about Africa and the other parts of the developing world. We are talking about strengthening the health systems in Wales here, but about Africa. We are not talking about strengthening the health system in Wales. So all these problems that are keeping humanity behind are actually in Africa. So it is very right and it's appropriate that we should be addressing these issues about Africa. And so we will win or lose by our efforts in Africa. The other point I need to leave you with is that there are deliberate efforts to do things deliberately differently. And there are deliberate efforts to do things differently. And that the ground is receptive to new thinking. So those of you who have had lots of problems previously, when you popped up with a new idea, may find that the ground has shifted. People are more ready to listen. And the emphasis on the stronger health systems is an imperative that all of us as players need to buy into. However well-intentioned your idea is, if you plan to parachute in and do your own thing without taking into consideration the health system, you are likely to be very frustrated when you monitor and evaluate your program because sustainability will be missed out. There are lots of gains if in whatever you do, you want to strengthen the existing systems. But the point, I think, is that health system strengthening is really different things for very many different people in very many contexts, and that whatever efforts we put in should be led by the components that need most attention. That's why in the workshop that I attended, I restrained myself from saying anything when there was a question on whether it can be adapted to that particular context. thank you very much for your attention. That's our little home in Arusha, the Central Southern Africa Health Community. And as you will notice, I haven't said anything about African health systems because I don't know if there is an African health system. But there is a lot that can be done in many African countries to improve the health systems within the region. Thank you very much.